Okay, I think more people will be joining, but I'm going to go ahead and get us started. I want to just welcome everyone. I'm Dr. Leah Carliner, the director of the UCSF Multiethnic Health Equity Research Center, or MERC. And I want to welcome everyone to MERC's annual research symposium, including our first ever Emerging Health Equity Scholar Awards. The mission of MERC is to promote equity in health and healthcare for ethnically and linguistically diverse groups through applied multidisciplinary research and by training the next generation of investigators committed to achieving health equity. We know that we have drawn many of you here with our outstanding keynote speaker, Dr. Eliseo Pérez-Stable, who we're very excited to have, and who, among his many other accolades, was the original co-founder of MERC. You will hear a bit more about him and hear from him shortly, but I hope that you will also make sure to stay for our second hour to hear from our awardees during their brief research talks and to engage with them during the Q&A that will follow. These Scholar Awards are intended to highlight and promote the incredible work of UCSF-based health equity scholars who are early in their careers. To learn more about MERC, please go to our website, follow us on Twitter, and feel free to contact us directly via email. I'm joined today by the two co-directors of MERC, Dr. Jane G. and Dr. Maria Garcia, and I'm going to hand it over now to Dr. G to introduce our keynote speaker. Thank you, Dr. G.
Thank you, Dr. Carliner. It's my pleasure to introduce our keynote speaker today. Dr. Eliseo Pérez-Stable is the director of the National Institute on Minority Health and Health Disparities at the National Institutes of Health. He earned both his bachelor's in chemistry and medical degree from University of Miami. He then completed his primary care internal medicine residency and a research fellowship in general internal medicine at UCSF before joining the faculty as an assistant professor in 1983. Dr. Pérez-Stable practiced primary care for 37 years at UCSF and supervised and taught students and residents in ambulatory care and hospital settings. Dr. Pérez-Stable's research interests have centered on improving the health of racial and ethnic minorities through effective prevention interventions, understanding underlying causes of health disparities, and advancing patient-centered care for underserved populations. He's recognized as a leader in Latino healthcare and disparities research. He spent 32 years leading research on smoking cessation and tobacco control in Latino populations in the United States and Latin America, addressing clinical and prevention issues in cancer control research, supporting early career scientists in research on minority aging in clinical and community settings, and addressing research questions in clinical conditions such as hypertension, asthma, diabetes, and dementia. He's published over 300 peer-reviewed papers and was continuously funded by NIH grants for 30 years prior to becoming NIMHD director. He was elected to the National Academy of Medicine of the National Academy of Science and the American Society of Clinical Investigation. He's also a wonderful mentor and friend, so please join me in welcoming Dr. Pérez-Stable today as our keynote speaker.
Thank you so much, Jane, and thank you, Leah, for hosting this. It's really nice to see old friends and new scholars. That's really the best part of this. I am going to spend the next 35 minutes or so, as I'm allotted, telling you a few highlights of some of the issues that we deal with. Not a lot of detail, and hopefully some of the comments and the questions will expand on it. I was asked to say something about the start of MERC, and I gather that no one else has left. When we started in 1993, it was a center grant that Gene Washington led from the Agency for Healthcare Research and Quality, AHCPR, I'm sorry, the Agency for Healthcare Policy and Research, I think that's what it was called. I gave it its follow-up. He approached me as he was writing the grant, and we partnered on it. I was going on sabbatical, so I wasn't going to do a whole lot in the beginning, but he got funded. And so we started that in 1993. I think the significance of the partnership was Gene was at the time had just been promoted to associate professor. He is African-American and obstetrician gynecologist and preventive medicine specialist. And I was in the Department of Medicine. I had just been promoted to associate professor. We were two scientists, clinicians of color at UCSF, rare at that time, and we partnered. And I think that's a clear message of what the synergy of value of partnering and not staying siloed. We obtained space at Mount Zion, not because the university gave us anything. They didn't, because Jean was based there as the chair of the Department of OBGYN at the time at Mount Zion. And we both were able to leverage our alliance to then get space at what was going to be Laurel Heights being developed as a dry lab space by the university. We each had FTEs, so we had that from the university. But I would say that we never really received any resources that we weren't already getting as tenured faculty at the UCSF. We really function on this idea of multiple disciplines, and that really became clear to us after just a couple of years. Broadly focused on minority health, all groups included. We weren't focused on just one group or one discipline. And I think as the more time we spent doing this, the more that was reinforced. And I think kind of create the opportunity for me at NIH, and then really from the beginning had younger scientists around us, people like Elena Fuentes-Affleck, who is at the high level of the hierarchy at UCSF, Anna Naples, who is now the scientific director at the NIMHD intramural program, and many others. We did get a center from the Agency for Healthcare Research and Quality, AHRQ, and also the RICMAR. The RICMAR has continued, and I'm really delighted that that program has been as successful as it has. So what are the main messages I think I'd want you to take away from this session from me today? First, in science, and how we can leverage science to reduce inequities. The first thing we have to do is use standardized measurement of all the factors that affect health. And that is a change in culture for our disciplines. And it is not going to be easy to get people to do this. People may agree on principle, but they don't want to do it. They prefer one thing or another. And we have to really decide, build consensus around measures and use them. We really have to develop more capacity in big data. So data science is a field that is running fast. It is grossly underpopulated by scientists of color. There are specific efforts that have been implemented by NIH to try and change that. But we need to be proactive about getting people interested and active in this, not just for electronic health records, but for many other options. The diversity of the workforce is a crisis that we have made painfully slow progress on. I'm not going to go over this today, but there's data that diversity of the workforce does reduce inequities. This is something in the clinical space. In science, it also promotes better science. And we cannot stand still with this anymore. The time has come for community engagement to be mainstream. This, I think, is as a consequence of COVID. People have been working on this for decades. My own first R01 was really grounded in community engaged research on tobacco use, and there's a lot of evidence that this can help advance health equity and research. We need to really create it as an infrastructure that is sustainable, so that relationships with communities is something we can maintain and support. And then finally, I think there's a lot of evidence on things that work well and that we don't do, we don't implement. So implementation science. The unfortunate part it's generally the case, people will complain about it, but when you look at the details, it's often the most disadvantaged populations that have the worst implementations. NIMHD has these sort of standard definitions that we use. So the first three bullets here were the congressionally mandated populations with health disparities, racial and ethnic minority groups as defined by the census, poor people of any color, and underserved rural residents. We introduced some of these qualifying terms. In 2016, sexual and gender minorities, we declared them as a population with health disparities for NIH research purposes, and I think it has helped synthesize and create more traction in research in this group, particularly around the intersectional issues. Note that all of these factors are either from identity or geographic location or socioeconomic status and not based on a chronic condition or disease. So a social disadvantage that results in part from being subject to discrimination or racism, and this is a unifying concept, all of these populations are, and being underserved in healthcare. So it unifies all of these populations with health disparities. So a health outcome that is worse in these populations compared to a reference group defines a disparity. We're having some internal discussions about whether or not we should modify this at some point and create more of an aspirational goal of health equity rather than compare to another group. But we haven't worked through that, or we just begun to discuss it. One of the basic messages I think that is becoming more accepted widely at NIH by all types of scientists, that these constructs are really fundamental in determining health. So this poorly defined social construct of race or ethnicity is a self-identified social construct, predicts so much that we can't ignore it. What does it represent? What does it really mean? There's lots of discussions from a variety of perspectives on this. And similarly important, not to be put at a secondary or primary role, is socioeconomic status or social class. And these are fundamental factors that we use for everything that we do. And I would argue that every clinical researcher and every clinician needs to consider these factors in everything that they do, until proven otherwise. So it doesn't mean that they're always going to be the fundamental cause, or that they're going to be contributing to that fundamental cause or influence what you do. But they have to be considered in all these factors. And this is probably relatively new for many clinician scientists, at least it was at NIH when I arrived. Just a few examples: Blacks have more strokes when compared to whites for the exact same level of systolic blood pressure. These are data from the Regards cohort study, a large observational study funded by NHLBI. We know most chronic diseases are more common in persons who are poor, and this is not because they behave badly. There are many structural factors that contribute to this. And then among persons with diabetes, and work done in Northern California, all minority groups had more diabetes, but also had less heart disease than people with who were white, and more end-stage renal disease. And these were not subtle differences. It was 30% less heart disease and twice as much end-stage renal disease in this study. This is now a little dated, but this relationship I'm sure hasn't changed. If you're poor, under approximately the poverty level in the United States, under $25,000 household income, you're 3 times more likely to die than if your household income is over $115,000. And even in 2013 US dollars, that is certainly well off, but not wealthy. So the fact that income does influence health, I think is extremely well proven. Now, how do you measure this? I won't go over all these factors. I think most of us use educational attainment, I should say, as a single easiest measure to use. And certainly in the survey research, many people try to use income if possible. The White House study, the UK used occupation, which is more complicated, although there's something to be said about that. For children, we often are thinking about parental factors. Life course SES is important, not the same being a cardiologist who grew up, who was the first in their family to go to college, versus a third generation San Francisco homeowner in terms of building up wealth, which is what that's getting at. And although we often use the well-proven methodology of imputing based on American Community Survey census tract data that you can get from an exact address, which is not easy. People don't want to give you exact address. And zip code is really much less accurate, actually. Some data from some groups have shown that this could be wrong by as much as a third of the time. So I think that needs to be further looked at. Just a couple of quick examples of stratified analysis. This is from CDC a few years ago. prevalence of obesity among youth by education of the level of the head of household. So the percent males and females, and then by the racial groups identified in the survey. And I just showed the two extremes here. So 16.9% of white males where the head of household had less than high school versus 9.6% where the head of household had college. And you can see this relationship is true across racial and ethnic groups. However, it doesn't behave exactly the same. You start off much worse, much higher prevalence of childhood obesity among Blacks and Latinos, and the benefit is much less for Black females, for example. So this is the kind of analysis we need, more of this. Often it's limited by sample size, but it should not be just adjusted away. And this is on tobacco rates from 2019, published a little over a year ago. Again, you see some interesting findings by race ethnicity in this case. So combustible tobacco, the one that matters the most, not a whole lot of differences except low rates for Latinos and Asians and higher rates for American Indians. But you see a very potent socioeconomic gradient based on high school diploma or undergraduate degree. And if you saw a graduate degree here, it would be half of this percent. Also, this showed rates for lesbian, gay, and bisexuals. One of the first national studies to show that, and shows this disproportionately a problem for sexual and gender minorities. There are many social determinants of health. We know that. I would categorize them as individual social determinants in the upper parts of the things that you measure in individuals, in persons. And then there are structural determinants, which is what most of people think about in social determinants, which are the factors that are outside the individual. So where you live, how in terms of housing, how much green space, access to broadband, which we now know how important that is, and other factors. Before the pandemic, NIMHD embarked on a project to try and standardize this as much as possible and vet measures. These are in the Phoenix toolkit. We went through an initial phase. It took about a year and a half. A couple of UCSF faculty were on our committee. We are now in phase 2 of this, so we're doing another set of measures. It was just launched in February of this year. And we are leveraging this and referring all of our applicants all through all of our funding opportunity announcements to the collection on Phoenix. Hopefully most of you have seen our research framework. It's a static sort of roadmap, if you wish, not causal direction or not comprehensive. But just to think about all the different things that a health disparities researcher will work on. Most of the work is in this first column here, individual. We really have had much less effort done on the right side of this framework. And although people know that behavior has been central, there's a fair amount now on biology and the physical environment, which again emerged more in the last 20 years. And all of this needs to interact with the healthcare system, given the importance of healthcare system for at least a third of the population, of adults population, that has a chronic disease or a reason to need to engage with the healthcare system on a regular basis. So let me share some data of things that we have analyzed here. This is a report from the NCI's intramural research program, their population science group. Meredith Shields is the lead author. Anna Annapolis and I collaborated on this, showing the excess deaths from COVID in the year 2020. So with the preliminary causes of death from the CDC. And you can see more males than females suffered from excess deaths. And clearly the data have been very consistent. The national data, I should say, have been very consistent when available, that Latino, African-American, American Indians have had excess death burden, both infections, hospitalizations, and mortality. This has not been changed in the 2 years of pandemic, although I haven't evaluated the latest numbers prior to this talk. Everything I've seen, most recently American Indian data published by the CDC, showed a similar mortality ratio between 2 to 3 compared to whites. These are soon to be published data from a collaboration we had with the Institute for Health Metric Evaluation, the people who do all the global burden of disease, Chris Murray, and in the affiliated with the University of Washington, looking at differences in life expectancy by race ethnicity. And in this slide, we're showing essentially the comparison to whites. And it's regional. And although it says Asian Pacific Islander here, just see this as Asian, because the data for Pacific Islander was not disaggregated fully until 2017. This is a state issue, not a CDC or NCHS issue. Sorry about that. Back to this. Interesting thing is, you can see for African Americans, there are areas of the country where they actually do better than whites. The purple color will be better than whites. Similarly, American Indians, although much fewer. And for Asians, generally longer life expectancy than whites. And this might be the first national estimates of life expectancy for Asians that has been published. And for Hispanics, Latinos, you see some particular areas, the San Luis Valley in Colorado and that northern New Mexico area, and then the border area, the Rio Grande Valley, where we have seen worse outcomes as well. This will be published in Lancet later this month. This is a study conducted by the NIMHD Intramural Division. Actually, Annapolis was the lead on this survey. They called it the CURB survey, related to COVID. 5,500 US adults. It was a representative sample. It was done online between December of 2020 and February of 2021. There are a lot of components to the survey, but this report in American Journal of Public Health is no longer in press. It reported on the perceived discrimination by race ethnicity. Again, you saw sometimes or always related to the COVID pandemic. Across the board, all racial and ethnic groups had higher rates of discrimination compared to whites. Asians had the highest, when you look at sometimes always is up to 30%. So I think that the limited English proficiency, less educated, lower income, and living in a big city or in the southeast part of the country, southeast central part of the country, also was associated with increased discrimination. And there are a couple other studies coming out of this. These are just a general look at access to telemedicine across COVID-19 and healthcare switch to telemedicine in March of 2020. It increased disparities, first of all, because people don't have as much privacy, they may not have broadband, or they use the internet on their cell phone. And what happened with many of the poor patients is they basically did not do telemedicine, they did phone medicine. And even that was limited in terms of, if they had a landline, it would be more likely. And you can see that less likely to use telemedicine included now more minority groups, lower and middle income individuals, as well as people who are on Medicaid. And it was really convenient for higher income and whites that was already present. I'll just mention SEAL as Community Engage Alliance that we stood up against COVID-19. Gary Gibbons and NHLBI and us are keeping this going with what we can. We have set up 21 teams. There's one in California. It is directed at the UCLA. I think Arlene Brown is the principal investigator, a former MERC trainee, I should mention at the beginning. She was a fellow with us. And I think that this is what we are referring to. This is one of the components that we're referring to as bringing community engage framework to the limelight at NIH. So all of my director colleagues have seen this and say, this is really great. How can we leverage this? How can we connect to it? We're the only ones funding it right now. But I think this is something that we're hopeful, and by saying we, I mean Gary Gibbons and I, that we can move this into the mainstream of NIH research. Let me turn to racism. I think just earlier today, I was listening to David Williams give a talk at one of our sessions at NIH. And I show this slide a lot. I've shown it for years now, including in the teaching I did here at UCSF. So when you ask people, this is from the Kaiser Family Foundation survey, in the past 30 days were you treated unfairly because of race or ethnicity in a variety of settings? And you see an answer of 53% of African Americans in the US, and this is past 30 days, saying yes to this, and over a third of Latinos saying yes to this, and they didn't sample other groups compared to 15% of whites. You know, we have a problem when this is so prevalent, and yet we have ignored for so long until recently, although that is a precarious attention. Thinking of this as a research component or construct, interpersonal racism is where 90+% of the work has been done. Everyday discrimination scale, many other measures that others have developed. Strong associations have been established with numerous outcomes in health, and these are well reviewed. There's the construct of internalized racism, or how people may say, well, no, I'm not discriminated against, but they've been impacted by it and have internalized it, are not aware of it, either cognitively, culturally, or biologically. And people try to get at this through things like, allostatic load, telomere length, and other things, although it is a harder one to really study in depth. Societal discrimination, or perceived societal discrimination, was one approach that I saw from an adolescence focused scientist in Southern California, which was quite, I think, important and relevant. Not what you've experienced, but what you perceive others to have, what the society is like, again, associated with behavioral mental health issues and substance use at a year follow-up in a cohort design. And then an area that has barely been touched is the secondhand effects of racism. What's it like growing up with someone or being around someone who is a victim of racism, and thinking of it in the same model as adverse childhood events or post-traumatic stress disorder, not as an acute, terrible event, but as a low-grade, long-term chronic event. And acceptance by science that this is, first of all, real, not done away with by limiting or reducing socioeconomic differences or changing laws, I think is one step in the right direction, but doesn't, of course, solve it. A couple of illustrations. This is a map of Washington, D.C., where I live. You can see the proportion of whites and blacks in 2020, and you can see this this foundation of structural racism in the United States, which is redlining. So the division of cities that represented sort of, quote, Negro developments or lower grade places, where banks were actually asked, or it was guided, that they shouldn't be providing loans to these areas for people to purchase property in these areas. And then, of course, highest grade residential property. Guess what? The whites lived in the highest grade, the blacks lived in the lower grade, and to a similar extent in many cities, the same thing was impacting Latino populations in the US with about a 15 to 20-year lag here. And now we see the average life expectancy differences. The whole idea of the zip code is more important than your genetic code comes from this effect, which is now illegal. You can't do this if you're lending, but the effects of this policy, designed in the 1930s and implemented with intent by the United States, has really laid this foundation, and is really the foundation of what we are seeing today of structural racism. More of the same, looking at the mechanism of pathobiology of chronic disease with a variety of factors, not just where racial segregation and SES impact issues around food deserts. And then scientists are exploring issues around the microbiome and immune system activation, chronic inflammation. This is the DC area. And for those of you who are familiar, east of the river is predominantly African American. There are more mixed neighborhoods. I happen to live in Ward 1, which is right here in Columbia Heights, and the Northwest is what most people know as, quote unquote, the nice part of DC. So initiatives on structural racism is things that I think I want to leave you with a clear message on. In 2017, we had a workshop on this. It was at a time when I was unclear. Hopefully, I think others might have been less unclear as to what was this as a research construct. How could we kind of formulate something of it? Out of this workshop, we decided we'd do a special issue We didn't do an RFA at the time, but then we did once the murder of George Floyd came and Francis Collins sort of pushed us to do more on this. We had a robust response. We're going to be funding. I don't know when the awards are go out. A number of R1s on this space, and all the institutes received the applications. I don't know exactly what the final outcome of that's going to be. More importantly, the Common Fund is focused on this now, and we now have an initiative called COMPASS, Community Partnerships to Advance Science for Society. It's a 10-year commitment from the Common Fund, not quite $400 million. Briefly, it will be transformational because the primary funding for the research projects, and we're hoping to fund 20 to 25 of these with the funding available, will go to communities. It will not go to academic research health centers. We expect the community organizations to leverage partnerships with researchers to be able to think about what they want to do and how they're going to implement it. There will be a coordination center, and there will be some national we call Health Equity Research Assembly, or like sort of a mega advisory board, if you wish. This is still being developed. It was approved by the Common Fund Council, called the Council of Councils. And so I'm not showing you anything that's secret. This is available on the website. But we're working out on the details. I'm one of the co-chairs of this effort, along with Shannon Zenk, the director of nursing, and Josh Gordon, the director of National Institute on Mental Health. Quick example of some of the things that could happen. This is a study done by Leonard Aguidi, who is a general internist in Milwaukee, doing a very small randomized trial, giving African Americans with type 2 diabetes and poor control. They all had a A1C over 8, and most of them over 10, and improved their A1C from 1.25 to 1.75% by giving them money linked to glucose measurement, education sessions, and attendance. So I think a very provocative approach. Cash assistance works. It's been shown many times in low and middle income countries in other topics, less so in health. And this is one example. Here's an example of structural racism, I think, where looking at maternal morbidity rates for Black and white deliveries. Severe maternal morbidity is common. It's about not quite 100,000 incident cases a year in the US, compared to 1,000 deaths from maternal deaths a year, disproportionately affecting Black women and American Indian women. Sorry about that. This is low Black serving hospitals in New York City. And notice that here, the severe maternal morbidity rate for Black women is actually lower than the severe maternal morbidity rate for white women in the high Black serving hospitals. So this is a structural problem. Not quite sure we know the exact causal factor here, but this is not the patient, this is not the race, and I think other in-depth studies by this investigator, Elizabeth Howell, have shown that. Now, one very recent evidence-based intervention that could make a difference is treating mild chronic hypertension. We used to call this mild hypertension. So a systolic blood pressure under 160 and a diastolic under 105. Now, in pregnancy, most women's blood pressure drops just because of the physiology. But in this randomized trial with 2,500 pregnant women, overwhelmingly women of color, you can see the mean age here. There was an active treatment group to get antihypertensive medicines. You never want to give drugs to women who are pregnant unless you really have evidence. Well, here's evidence that you can reduce the composite events by an absolute rate of almost 7%, including these outcomes of preeclampsia, preterm births. Placental abruption was not different, and then fetal or neonatal death in the first month. So keep this in mind. This is something that we probably, I mean, it's not what I ever did as a general internist, but this is clearly impacting the public's health. Now, Patient-clinician communication matters. We have a funding opportunity announcement on this and health disparities. It's been linked to better satisfaction, better adherence, better outcomes. Lisa Cooper did some elegant studies now 20 years ago showing that concordant visits were better. There's actually a randomized trial showing that if you were assigned to a Black doctor and you're African American, you're more likely to adhere to preventive services. The MEPS database, the Medical Expenditure Panel Survey, shows that African American and Latino physicians care for over half of the minorities in that cohort, and almost 3/4 of patients with or people with limited English proficiency, and more likely to care for Medicaid and uninsured patients. So I think we have lots of empirical evidence that this works as an intervention, and yet we still see this huge gap. We know the interpreter literature, so for this group, so I'm going to skip this slide in the interest of time. I've emphasized the issue of diversity of the workforce. I want to make sure that the emphasis here is not just on inclusion of people from all backgrounds, sort of what some have called the snowflake diversity. Yeah, we like everybody to be different. You know, we want to taste your food, cultures, appreciate for differences, but really should be targeted for those who have been the victims of exclusionary practices. It's not just a matter of, oh yeah, we want to see everything from everyone. And that's a way to address the issue of diversity in the workforce. It does lead to better research in science. I think there's good evidence for that. Whether it leads to more engagement of underrepresented populations in research is an empirical question that would need to be addressed. Put in a quick plug for our Health Disparities Research Institute. We just sent out the acceptance letters to notices to our 2022 class. We're doing it virtual now, so it's gone up the total to 60, 70 participants. It's a great opportunity for your scholars. I think we've had a couple from UCSF, a few from UCSF, maybe not many, and maybe the UCSF folks are the least ones to need it. But I do encourage you to do it. It's a great opportunity. And once we go back in person, I think it has special meaning. This is one of those great Zoom screenshots that you can take a sense of the picture. About 20% of our participants are physicians, well over 70% are women, and without, of course, using that as a selection criteria, about 60% are for underrepresented groups, particularly racial and ethnic groups. Let me finish with just a couple of global sort of recommendations. So how do we promote health equity in healthcare to reduce disparities? So the fundamental first factor is we should have insurance. And of course, we can't do that. We can't just mandate that. We've made progress with the ACA. Insurance rates were reduced, uninsured rates, I should say, were reduced by about 1/3. They kind of held around during the Trump administration, and now hopefully this current administration will implement measures that will, again, make it easier for people to be insured, either expansion of Medicaid or in the marketplace. We also need to think about, being sure that we make this driven on quality and outcomes, and evaluate organizations or healthcare systems on the basis of quality, not just in terms of what is usually done. Well, how many mammograms did you get, or what was the time from someone who get into the ER to get an intervention for coronary disease or stroke treatment, but also equity quality measure. And I think this is beginning to get some traction at CMS, although it will not be, again, a simple one. But many of these other factors, coordination of care, you've experimented this in different systems, making care accountable, sort of population basis, not just care of individual patients, be responsible for a population, is a mechanism by which I think we can do better. I've emphasized community engagement. I again want to re-emphasize this as a model of care. If we just go from the scientist or the clinician scientist to the community or the patients, will miss opportunities to learn, and it won't be accepted. So we need to really build these sustainable relationships, build trust in order to be successful in how we deploy our interventions. I think the example of the vaccine was one that woke everybody up. a tremendous product. Yes, it's not quite as wonderful as it looked like in the initial trials, but it definitely does impact mortality and severity of disease. And rolling it out, we thought, hey, everybody will just want to come line up and get it. And some people did, but a lot of people didn't. And yes, there's been misinformation and other things in factor, but that's, I think, sobering to us that we need to do more than have a wonderful product. We need to be able to deal with communication and deal with community engagement in a very positive way. Just to mention two things about our institute. Our budget, the first year I was director was not quite 270 million. It is now 400 and not quite 460 million. We got a big discretionary increase this fiscal year, not as big as we expected, but it still was the largest ever. This will allow us to fund more R01s, improve our award success rates, as I'll show you. Most of our other increases have either been because NIH increases overall, or there's been a particular increase like the multiple chronic disease research centers that when increased from 20 to 21 was a congressionally mandated increase, of which UCSF is now the coordinating center for that program. And this is an example of our R01 award rates. Our numbers are small compared to other institutes, but you can see that from fiscal year 1920 to 21, improvement in award rates for early stage investigators and for established investigators as well. And so just wanted to leave you with that. I'll stop here. These are just global things. We always need multi-level interventions, particularly in healthcare settings. Mechanistic science is very relevant to us as well, both from a behavioral and biological one in social determinants. I talked about communication and then implementing structural change to modify individual and group behaviors. Sort of the idea that you put in stairs that are easy to use, people might use them, and then you get more physical activity. Or even a randomized trial in the schools in Southern California that we funded a number of years ago, where actually the education of the students about drinking less, consuming less sugar-sweetened beverages had little to no impact, but giving access to chilled water, it was in LA, really was the factor that mattered the most, and they were not, I think, expecting that. So thank you for your attention. I'll end the slideshow, stop sharing, and hopefully have time for questions. Thank you.
Thank you so much, Dr. Pérez-Stable. And we have a couple of questions that have come in. So thank you for that comprehensive overview of health disparities and future research direction. So I will start off with a couple of the questions that came in. So one attendee asks, can you speak more on other factors for why low-income, low SES populations are less likely to use telemedicine and how that has increased health disparities?
Well, some of it is common sense. And the same reason why COVID was more likely to be, people were more likely to be infected. People who are working class or are not professionals often, first of all, they don't own a computer. People thought computers were the new gimmick, when I was younger. Now everyone has one of these guys, right? The cell phones. They have all the power they need in here. So, and they don't get unlimited data plans. So they're paying on a usage fee. So all of a sudden they're having a visit with a doctor who wants a video visit on their phone, and they're paying for it because they're paying for data. And so we didn't think of that. It didn't bother me because I have a computer, I have a camera, or I have a cell phone with unlimited plan. So that's one thing. The other is privacy. If you have 2-3 families living in a single household, or if you have 3 generations in a single household, how do you get people away in a corner to have a visit about confidential issues with your clinician? It's hard, just like it was hard to get people isolated. So self-isolate. No, you can't do that. On top of the fact, the people are living in multi housing in buildings with multiple apartments, et cetera, where there's also increased risk of transmission. So those are fundamental. And observing what clinicians were doing with low income or community clinic FQHC patients, I would say 90% of the time their visits were phone. not with no video, and you needed a photo because I don't know, swollen foot or a skin lesion, they would take a picture of it and email it to or send it to the doctor, and not as opposed to everything being done video. So
we have another question that came in about can you please discuss how census tract or other area-based SES or social determinants of health variables can be used as more than just imputing missing individual level measures. So it can give an idea how area-based measures may represent other constructs beyond individual person level variables.
I think let's see if I understand the question. So I think Nancy Krieger was one of the first to do this in the 1990s, and there's a classic paper in the HAPH where you can show that if you don't have the individual level data on someone for their income or education, or you can impute the census tract data. The median usually is what's used, so the median data. And that is pretty good in populations when you have large samples. So in evaluating large data sets where you don't have as rich a rich data set on individual variables, you can do that with what's available from I say census, but I really mean the American Community Survey, which is the annual updates of a random sample that generates these data. So you can get things like education, percent foreign born, limited English proficiency. Of course, you get sex, age, and these are routinely done in public health science when possible. For me, it's more satisfactory to have the actual question from the individual. Okay, what did and use those data. So you're not imputing an individual value as much as you're using it as a variable for the area, for the analysis of large data sets. You can derive imputed data from area level estimates like this, and use another data set that you collect, because you didn't let's say you have a research trial and you didn't ask about socioeconomic status, but you know where everybody lived, or at least know their zip code, then you can use imputed income or education in that data set, because you're not required to report socioeconomic status to the NIH. People do usually report age, sex, and race ethnic categories, and whether they're US or non-US born. And so that's one way of trying to get at that, and whether or not we ever get there or not depends. But I think there's interest in doing that from NIH side, but they're worried about burdening the investigators. So does that help? I'm not sure I answered the question, but.
Oh, that's great. Another question that came in is, can you give some information about how internalized racism can be measured when examining disparities? Any examples? And then I could probably add a little bit to that question in terms of, for early stage investigators who are thinking about including some of these constructs in their work, with beyond FENX, or in addition to, are there other resources that you can guide them to in terms of defining these constructs?
The brief answer is I don't really know how to do this, because it starts off with someone who says, no, they're not a victim, they've never had it. But you're guessing that maybe they have, or you can get at it from other ways. That people in secondary data analysis, you can take these measures like, allostatic load has been the most commonly one. I've worked in that in my own my own lab at NIH with Eric, who also was at Eric Rodriguez, who was at MERC as well, in trying to evaluate this. These are 10 measures, biomarkers or physical exam measures that can be put together as a composite and then associated with things around unhealthy, and we've done it with unhealthy behaviors, depressive symptoms, things of that type, and then adjust for other factors in the database. We did it with Haynes, we did it with the Hispanic Community Health study on Latinos. Others have used telomeres. There's a guy I think he's in Mississippi or Alabama, who's an aging investigator. He's Asian American, I'm not remembering his name, who's done work on telomere length. There's a limited variance there because telomeres don't change all that much. There's about a 30% change over the life course. And there are other biological measures that people have tried to correlate with experience of perceived discrimination or exposure to racism in that way. I listened to a talk by Mark Hayward a couple of weeks ago that we hosted, where he has data from the Health and Retirement Survey that if you're African American and were born in the Jim Crow South, you are I guess you could say call it the old Confederacy. You have a higher risk of cognitive impairment, independent of everything else they adjust for. And this is a consistent finding that I think, again, would probably reflect some exposure to structural racism growing up. And I'm not sure that, these are the kinds of approaches that people have taken. But I'm not, again, people have used reactivity, cardiovascular reactivity as well, although that's very acute and not sustainable. The studies on hypertension have not been as good, have been all over the place. But you can get, if you show someone a sort of an anger-provoking video, their blood pressure and heart rate go up. This goes back to the 1980s, that people were doing that. Apartheid in South Africa, and you're African American, people would, and that's a cardiovascular reactivity response. But does that lead then to sustained cardiovascular outcomes? That wasn't shown at the time. So I think that's another approach that people have done more experimentally.
Great, thank you. And in the last few minutes, actually, I'm gonna take over and ask one of my own questions. You mentioned the Community Engaged Alliance Against COVID, and I know it's hard to imagine a world post-COVID or after COVID, but has there been any thought or talk about using these same networks to address other health disparities or other health conditions? And how can funding mechanisms actually foster and incentivize community engagement?
The SEAL is, as we call it, is really focused on COVID. That's what we started out with, and that's what we're doing. It's not inexpensive to have SEAL, even as it currently exists, without covering the whole country. Initially, there was lots of money laying around, possibly from the government because of the COVID response. That's gone. So right now it's up to the institutes to do it. And yes, long term, I don't know, or medium term, our intent is that this will be not just focused on COVID, but we're really building a network, an infrastructure to address disparities in general. And as we evolve, we'll see where it will take us. Will SEAL be able to do everything? No. Will it do more than COVID? We think so. We hope so. That's our goal. So I'll leave it at that. It's hard to get too specific. Some people say, well, we got another year of SEAL. I mean, it's not a 5-year grant. It's done through other mechanisms. There's a lot of uncertainty. There's just right now a commitment to do it, and I'm optimistic that that commitment will yield results. But we need action from others. That is not the institute directors. So,
for another brief question, one participant asked, maybe I missed it, but do you have collect data on health disparities for those with disabilities?
So this is a critical issue that's come to the forefront under the current administration with equity theme. So there are a number of chronic conditions, that you look at, people do worse in their health outcomes. People with severe mental disorders, 5-6% of the population in the US live 20 years less than the average American. And it's not just the disease, it's the treatment and their social factors, all of them combined. We don't know. They're very disadvantaged. Similarly, people with physical and intellectual disabilities also have worse health outcomes and suffer from both these groups suffer from significant amounts of systemic discrimination, lack of access. So a lot of the levers for those populations are policy and regulatory based, not research. And if someone can't get to a mammogram because of physical disability, then they're oh, you're not adherent, you're not compliant with your well, it's not true. It's just there's no way for me to go because I don't have the transportation didn't show up, or The machine isn't set up to deal with someone with my condition. And so I think that there is a lot of interest in how we can address this. There's also, not as well known in the community that, if you have Down syndrome, and of course we live into adulthood, the risk of Alzheimer's or related dementia is substantially higher at a very early age. So usually people in their 50s, assuming many do live well into adulthood. At NMHC, I think we want to be able to promote the whole equity theme in not just in these populations, but in all populations, and particularly the intersectional theme. So a person of color who also has a physical disability or intellectual disability, similarly poor people, and then many, if not the majority, are. Currently, our populations with health disparities that I showed you probably make up about 60% of Americans already, if you think about it, between all minority groups, all people who are poor, people who live in rural areas, and sexual and gender minorities. So, we could just be population health and not worry about disparity populations. That's another option, but Congress gave us our name, so I don't think we can change it. So.
Great. Well, thank you so much. We look forward to your comments for our awardees presentations. And so we will move on to the first presentation. As she gets her slide, I will present Dr. Miranda Hill, who is a social and behavioral scientist whose research explores the intersection between systems, social networks, and health inequities among medically underserved populations in the U.S. South. She received her MPH and PhD in health promotion and behavior from the University of Georgia and is currently a National Institute of Health T32 postdoctoral scholar fellow in the Department of Medicine at UCSF. And so we will let her share her slides and present.
Hello, thank you for that introduction, Maria. That is a tough act to follow, but I will do my best. So my name is Miranda Hill. I am a social and behavioral scientist and postdoctoral fellow in the Department of Medicine. And I am just so delighted to be here today, to be in the first cohort of the MERC Health Equity Scholars, and to also be able to share with you the research that I've done in HIV prevention equity. So I was asked in preparing this presentation by Dr. Jane G. what motivates me, and that was very easy. It's my family. I am a first-generation scholar, and I am just continually inspired by their resilience, their support, and their belief and faith in me. And so I'm going to talk a little bit today about a project that I led as a larger collaborative effort to inform the development of programs to end the HIV epidemic in Atlanta, Georgia. So if you're not aware of EHE, or Ending the HIV Epidemic, it's a cross-agency initiative that involves CDC and NIH, and the goal is to reduce HIV transmissions by 90% by the year 2030. A key part of that strategy is to distribute pre-exposure prophylaxis, also called PrEP for short, to prevent new transmissions. And PrEP is a daily medication regimen that people can take. And if you adhere to it, it reduces your chances of uptaking and developing HIV by 97%. It's been shown in clinical trials. And so there are several priority areas that this federal initiative focuses on, and they're sending the resources to. Atlanta is one of those priority areas that I have operated out of throughout when I was in my graduate school career. And they are also focusing the intensity of their efforts on high priority groups that have a high burden of HIV, such as young Black, gay, and bisexual men. And so this was research that was done within this local context to help inform the development of programs that are funded by that. So the bar chart on the left shows the incredibly high burden of HIV in Atlanta as compared to the state, region, and country. The rate of people newly diagnosed with HIV per 100,000 in Atlanta is 3 times that of the USA at 44 per 100,000. And then we also see, when we look closer at these kind of geographical graphs, that the burden is also uneven across the city and among different groups. So infections are dense within the innermost areas of the city, and they are also highly concentrated among gay, bisexual, same gender loving, and men who have sex with men, especially African American. The HIV diagnosis rate among African American men who have sex with men is 5.6 times higher than white gay men. And so this preliminary surveillance data is really important to help inform local efforts to address ending the HIV epidemic. So PrEP may be a critical tool, right, to address these local inequities. However, biomedical tools are only as good as the ability of systems to get those tools to medically underserved groups. PrEP is not available over the counter, excuse me. It is something that has to be prescribed. And so that requires people who may have a difficulty with engaging in healthcare systems to get into them, to be prescribed PrEP, and then you have to continually be retained in PrEP, right? Because it's a daily regimen. And there's some surveillance data that shows that a lower proportion of Black gay men are actually using PrEP compared to white gay men, even though they are aware of it. And so the research question leading this research are, what are the barriers and facilitators to PrEP use among young Black, gay, and bisexual men? We adopted an ecological systems view to exploring the determinants on multiple levels, just to really dislocate our examination away from the individuals and problematizing their behaviors, their beliefs, their attitudes. So looking at interpersonal, person-to-person interactions between patients who are on PrEP and their providers, also with their romantic partners. We're looking at their social network, norms, their support, their influences, as well as structural factors, especially structural factors like policies and the availability of PrEP across the city. And so we use rapid ethnographic methods to investigate our research questions. Rapid ethnography is something that is growing in popularity during the COVID-19 pandemic because it allows you to do community engaged research. It's a qualitative method, so you're engaging with people, local stakeholders, to try to collect as much rich data as you can about urgent health matters. It's been employed previously in emergency responses such as the Ebola outbreak internationally, but it's really good when you have limited time and resources. And with this project, the federal funds were being distributed to the city of Atlanta, and so there was a sense of urgency with trying to identify some of the barriers and determinants of PrEP with this group. What you see here is just a general timeline, and it's hard to design a timeline to describe rapid ethnography because it's very iterative. You're always engaging community stakeholders, you're collecting data at the same time that you're taking conversations in the form of making field notes. You're also audio recording interviews that you're doing with different stakeholders. You're coding and developing analyses. And again, this is all a collective, diverse team, which includes researchers, policymakers, and CBO leadership. And so with this particular one, it took place from December. So we had a very short amount of time to collect a lot of data. And so once we collected that data, it was all put into a qualitative package called Deduce. And this was really helpful for helping us comb through the conversations and the notes that we had to identify themes. And so we started with a coding template that was based off of simple ecological categories ranging from individual to structural. And then we also importantly applied an intersectionality theoretical lens with really focusing on the role of structural power dynamics among young Black gay men due to their stigmatized identities and social disadvantages. Within there, we were able to use coding matrices within Deduce to see the intersection of themes. And what you see here is a really fun feature of Deduce, which generates a coding cloud where you can see where some of your prevalent themes or codes are. Immersive was something that popped out a lot, provider support, and then life stage emerging adulthood, which is something that I don't see that's recognized in the literature a lot when we're looking at young Black, gay, and bisexual men in HIV. So I wanted to highlight this quote that stuck out to me. I was the lead ethnographer again on this project, and it really highlighted the strengths of the Black gay male community in Atlanta. It captures the energy, the vibrancy, the momentum and growth of that community and how it's thriving in Atlanta. And so I don't want to disproportionately focus on the things at-risk part of it. But one person, actually a prep, someone who was involved in prep education mentioned to me that Atlanta is to Black gay men what San Francisco was to white gay men in the 80s. And so I thought that was a really interesting quote as he was talking about the community. I would like to think how we could leverage those strengths to help promote greater access. And so with our themes, we superimpose them onto a socio-ecological model. A lot of these things intersect between categories, and so don't get too caught up into those, but the whole goal was to help us to identify what are some of the really prevalent things that should be addressed in any PrEP interventions or healthcare reform efforts. Ease of PrEP access was something that came out, and it's not necessarily what you think in terms of ease of accessing PrEP and its availability. It has to do with the individual and what they think is easy for them. So while some people felt like mail delivery programs work for them, that wouldn't work for people who are unstably housed. And so they would need to go into a clinical setting, or if they didn't like the clinical setting because of stigma, they might want a community-based setting. And so it's something that's very subjective and should be interpreted as so. Another thing that stuck out to us was life stage. Again, just recognizing that these are young, busy, mobile men, and they have a lot going in their lives. So how can we meet them where they are? Something that was really novel to this study was, and I can accredit this to the intersectionality framework and the analysis, was looking at this intersectional spatial HIV and social identity stigma and the divergent impacts that it had on PrEP use. And so we're looking at this really common area where geography, race, place, and sexual orientation intersect. And so I pulled out a quotation that really encapsulated this. I had one person, well, several people that said things like this, like, I know it's bad, but living in Atlanta and the high HIV rate, so they were aware of the background prevalence. And this particular person goes on to talk about how it motivated them to be more adherent to PrEP when they moved to Atlanta. So you could say that, like, yes, biomedically, that was a positive thing. I wonder what the cognitive effects of that are. And with some people, it was prohibitive to them actually accessing PrEP in settings that also offered HIV treatment, especially in those settings. And so I worked with stakeholders throughout the whole process and in the end to develop recommendations that could be considered, and all for just meeting young Black, gay, and bisexual men in Atlanta where they are. And a lot of it really evolves around having flexibility in care delivery. So again, mail delivery systems for some, having some be able to pick it up in a community-based setting, some in a clinical setting if they're comfortable there, having flexible clinical hours because they're in school, they're at work, and they're doing other things, and addressing some really important knowledge gaps. And that doesn't have to be patient to provider, it can be through the community, but they should definitely know how to recover HIV protection if they miss some doses, because that's going to impact their risk for contracting HIV. So future directions for me, the manuscript communicating these results is under review. Fingers crossed that we'll get it published, and anyone who's interested can contact me and I'll be willing to share it. Collecting pilot data to support a K award application that I am submitting in September. So many thanks to the participants and community stakeholders, the Georgia HIV Behavioral Surveillance Unit, MERC, and all the senior advisors at UCSF who helped me with this research.
Great. Thank you so much, Dr. Hill. That was a wonderful talk. I'm going to ask people to put their questions in the Q&A for all of our awardee talks, and at the end we'll have a chance to get to those. So please, as they come up for you during the talk or right after the talk, go ahead and put your question in the Q&A. And thank you again, really great talk. Our next speaker is Dr. Rachel Sklar. Dr. Sklar completed her PhD in environmental health sciences at UC Berkeley, is currently a postdoctoral scholar in the UCSF program for reproductive health and the environment. Dr. Sklar's research has focused on quantifying exposures encountered by people who live or work in contexts that are disproportionately burdened by failed infrastructure, contaminated environments, and climate change effects. And she is going to share go ahead and share your slides with us, Dr. Sklar, and she'll be talking about linking the housing crisis, wildfire smoke exposure, and preterm birth in California. Take it away. Thank you.
Thank you so much. And thank you so much for the honor of speaking at this event. I'm super grateful to be here, and I'm eager to learn from the work of my other fellow awardees, and of course to join this amazing community of like-minded researchers. So I'm an exposure scientist and environmental epidemiologist in training. I've focused most of my work and research on environmental exposures to workers, incarcerated populations, and now pregnant populations in California. And today I'm going to talk to you about a study that I'm just sort of starting, which is linking the housing crisis to wildfire smoke exposure and preterm birth in the state. As you all probably know, wildfires are increasing in their occurrence and their severity worldwide, but especially here in California. There's an obvious ecological and public health crisis associated with this. And from a public health perspective, growing wildfires are concerning because the smoke contains many pollutants of concern, including carbon monoxide, NOx, ozone, particulates, PAHs, VOCs, just to name a few. And the exposure to smoke has been known to cause a wide array of health effects, including reproductive health effects, which are the focus of my research. In California, up to 5% of all preterm births are attributable to PM 2.5. And then about half of that is from wildfire smoke, although, that may be increasing in these past few years with the heavy smoke loads that we're seeing. And there's a geographic coincidence of places where wildfire smoke exposure are high and where there are excess preterm births. The San Joaquin Valley being one of those places. Because of its topography, it has been known to collect air pollution in the basin. And the same is true for wildfire smoke. The San Joaquin Valley also has a particularly high incidence of preterm birth compared to other areas of California and to the rest of the country. One of the most concerning things regarding the growth of wildfires is that there is also a growth of communities that are close to where the wildfires burn, or within areas that receive a high concentration of smoke pollution during wildfire events. As many may already know, there's a massive housing crisis in this state, which is pushing people from coastal urban areas, urban cores as we call them, to inland areas like the Central Valley and the Inland Empire. So people are being pushed out of those places that are in general more climate resilient because they are not as hot, less prone to burning, and keep people close to where they work, avoiding the emissions from commuting. People are being pushed out of those urban areas to inland areas that are closer to the wildland-urban interface and impacted by high smoke levels, have higher outdoor air pollution, and have been shown to have higher indoor air pollution too, due to the effect of high temperatures pushing that outdoor air into indoor spaces via infiltration mechanisms. So yeah, what we have here is a situation in which, due to the rising housing costs, the lack of new housing supply, gentrification in coastal areas, lower income populations have been moving out of these coastal areas to inland areas that are more vulnerable to wildfire smoke exposure. And in terms of who exactly is moving out of these coastal urban cores to these high-risk places, well, it's low-income people of color who can't afford to live in places like LA and San Francisco anymore. According to a study done at the Turner Center at UC Berkeley, the lowest income people or the lowest income out movers, so those who were leaving the Bay Area, were more likely to head to other affordable markets in California, like Modesto or Fresno. And these are areas that are close to burns and impacted by heavy smoke exposure. So 55% of those leaving the Bay Area earning less than $50,000 a year stayed in California. The opposite was true for richer households. Most of the higher income households that left the Bay Area left for other parts of the country, other urban areas, Seattle, New York, DC, etc. As you can see, just 1/3 of the households earning more than $200,000 a year stayed in the state, and those that did were most likely to go to other high-cost coastal regions like San Diego. And Dr. Pérez-Stable talked about how exclusionary loaning practices, also known as redlining, led to these place-based health disparities historically, and how that has become illegal. But there are these modern housing policies that are essentially driving the same exclusionary trends, pushing low-income populations of color to areas that are more prone to pollution that subsequently lead to health disparities. So while many low-income folks are being pushed out of the urban core, not everyone can afford to move to those more affordable areas because moving costs money and time and resources. So in the urban core, there are also people who are living in smaller, older homes, which are two factors that actually increase the infiltration of outdoor pollutions into home environments. And many of these homes have no HVAC. The residents don't have access to portable filters during a fire event. And I hypothesize that many of these older homes are in previously redlined areas, which are known to have maintenance issues, homes that were poorly built to begin with, and again, may allow for more infiltration of pollution, including wildfire smoke. So that was a bit of background on the research that I'm undertaking, and I'll talk a little bit more about the specifics of my postdoc, which is to understand how housing factors, like the physical factors of the actual building and place-based factors, may influence prenatal exposure to wildfire smoke and ultimately lead to preterm birth. So the data that I'm using for this study include birth certificates, which specify birth outcomes for all births in California. We're looking at the period between 2008 to 2016. The number of smoke days and average temperature and humidity by week of pregnancy for each of the births at a specific mother's address assigned to each pregnancy, basically. And this is from the EPA's Community Multi-Scale Air Quality Database, CMAQ. And then we've got home building physical factors from the California tax assessor. So this is individual level information on the square footage, the year built, the renovation year, construction type for every house associated with a pregnancy. And then we're also looking at the redlining grade of the mother's address for those mothers that may live in an urban area that was previously assigned one of the 4 grades by the Homeowners Loan Corporation, A being considered best and D being considered declining, and hence the term redlining. So that's our data. My first aim is to really answer the question of who lives in the homes that are most vulnerable to smoke infiltration. We know from building infiltration literature that the factors that most affect infiltration are square footage and building age. So small and old buildings are more prone to high rates of outdoor infiltration. So I'm going to build a machine learning model to identify the factors associated with each race and ethnicity group. And my hypothesis is that minorities may be overrepresented in the homes that have physical factors that drive the infiltration of smoke indoors. These homes are older and smaller, and those that are in hotter climate zones, and potentially those that are in previously red-lined areas. And my second aim is to classify individual homes into subgroups based on housing factor similarity, and then look and see if a certain type of home affects the relationship between smoke exposure and preterm birth. This would suggest that infiltration may play an important role in the relationship between the exposure and preterm birth. And I hypothesize that a stronger association between exposure to smoke and preterm birth will exist for births that are associated with homes that are older, smaller, previously redlined, and in hotter climates. And the policy goals are basically to, show that for homes that magnify this exposure outcome effect, we should really be looking at policies that mitigate outdoor smoke exposure. For example, if a cooling system is installed, people can keep their windows closed during high smoke days, and portable air scrubbers can be used to decrease concentration of particulates that are coming in. It took a long time to get our data from the tax assessor. So cleaning it has been the real challenge of all this, but we've managed to match birth records to the housing data, and neither was standardized. So it's been quite a lengthy process, but we're really excited because now we have matched individual level data for households of all pregnancies in the state for the last 10 years or so. And just wrote a commentary on the relationship between housing policy, smoke exposure, and reproductive health in California. So watch out for that in the International Journal of Gynecology and Obstetrics. And yeah, by sometime this fall, we hope to have results of the models that I mentioned. Thank you so much for your attention and attendance, and please email me for any questions or ideas.
Hi, my name is Celia Kaplan. Thank you, Dr. Sklar, for your presentation. Extremely interesting. I'm a member of MERC, and it is with great pleasure that I would like to introduce our third awardee, Dr. Jennifer James. Dr. James is an assistant professor in the Institute for Health and Aging at the Department of Social and Behavioral Sciences and the Bioethic programs at UCSF. She's also one of our scientists at the Center of Aging and Diverse Communities. This is a center funded by NIA and that Dr. Pérez-Stable established over 20 years ago. She's a qualitative researcher and Black feminist scholar who conducts community engaged research at the intersection of race, gender, and health. Jennifer, we are ready for you when we're ready.
Wonderful. Thank you so much for the introduction. I'm so grateful to be here. Thanks everyone for sticking around. I know I'm coming at the end of an hour and a half of Zoom, and I appreciate it. It's an honor to be with you all today. I think I am the awardee who is moving rapidly away the fastest from emerging towards mid-career, which is a little bit scary. As was mentioned, I'm an assistant professor in the School of Nursing. I'm going to skip over my sort of intro slide, thanks to the great introduction from Dr. Kaplan. But yes, I do qualitative research, community engaged research, and a lot of my research right now is focused on incarceration and health, and that's what I'm going to focus on for my talk today. I wanted to just say a little bit about how I got to my current research. So back many years ago when I was in college, and I started learning more about racism, more about Black feminist theory and intersectionality specifically, they really spoke to me. They were really quite transformative in my thinking. After I finished college and I was in graduate school for social work, I was working in hospitals and ICUs, and I became even more interested in end-of-life care and cancer. That's what inspired me to come to graduate school at UCSF to get a PhD in sociology, was wanting to gain a better understanding of end-of-life. And I had the opportunity to sort of really combine these interests through my sociology PhD program by doing a dissertation focused on the experiences of Black women with advanced cancer, using intersectionality as a lens for that project. while I was doing that research, I met several people who were facing cancer while incarcerated or while in and out of jail. And it sparked an interest in me in understanding what it would be like to be incarcerated while facing a life-limiting illness. And that was just a thing that percolated in my brain for a while. I started a postdoc at UCSF in bioethics, focused on ethical legal social implications research of genetics and genomics around cancer and clinical trials, which I'm still engaged in that area of research as well. But in 2019, I was able to apply for a pilot through the CADC, Center for Aging in Diverse Communities, to turn back to this idea of really wanting to learn more about incarceration and health. So that project, which I'm just going to tell you really, really briefly about, I did interviews with formerly incarcerated older Black women who had chronic illness to learn about their experiences with health and illness before, during, and after incarceration. And I'm just going to tell you very briefly about some of my themes. I decided not to do longer on this talk on this project because I wouldn't have time to show you all my quotes, and that's just too heartbreaking for me as a qualitative researcher. But a couple things that emerged through these interviews that have been, I think, really foundational to how I look at this topic more broadly. First is the amount of gatekeeping there is to care while people are incarcerated. You have to prove that your character is what people describe. You have to prove that you're believable when you're sick, and you have to prove that your illness is severe enough to need care at sort of several different intersections in order to access care while incarcerated. Once people are sort of in the room getting care, they describe being treated as providers as an inmate and not a patient. So not being really treated with that humanity that is needed to develop a patient-provider relationship. Patients also have a lack of autonomy in their care. You often are presented with, this is the care plan, do you want to do it or not sort of given multiple choices. You're not often given all the information that you need to make decisions. So it's a really difficult space to face chronic illness or life-limiting illness or serious medical decisions. But while incarcerated, people obviously are removed from their communities and their families, and they form intense community and family inside. They provide a tremendous amount of caregiving for each other, both in terms of at times activities of daily living, in terms of emotional support, and in times often offering medical advice to each other, because there's this massive mistrust of the medical system inside. I think this is expected, and we see it in many areas, and it ends up leading to a lot of refusal or delaying of care. People don't seek out medical care if they don't have to. Either they don't think they'll get the help that they need, or they're worried about what will happen when they do. And just one quote I wanted to share from someone who's been released, and she says, I'll be 65 in a couple months. It's been hard. I think I could probably be in better medical and better health if I trusted them, the healthcare workers inside, but I may be in better medical health because I didn't trust them. She thinks if she'd attended to her chronic health issues sooner, that would be good for her health. But at the same time, she feels like she could have faced worse consequences by going to medical. And this extends beyond prison, right? She continues to not access care regularly because of this habit she established over decades. And I think this speaks to why we must center and include incarceration when we think about moving towards achieving health equity. So coming out of this research, I started developing a framework for thinking about how health decisions are made in this space inside prisons and jails. And if we sort of think about, decision-making should happen sort of based on informed consent, personal values, individual autonomy, and obviously that always happens within the context of the patient-provider relationship where you should have trust and be able to engage in decision-making. But in prisons, there's this layer of the punitive nature of the system and all the restrictions that are put on care that really informs this, not to mention the oversight and policy and the really complex layers of who decides what's allowed and what's not. And all of this is informed by, fueled by, the intersection of these really complex systems of oppression, obviously racism, sexism, classism, but also really thinking about state violence and the punishment and social control, all of which lead to people being incarcerated in the first place and influence their health and their health decision-making. So I was thinking about this, thinking about my next projects, and then of course, COVID happened. Oops, my clicker is not working. Okay, COVID happened. And like many people, I shifted my research for momentarily or for a couple years to doing a lot of work thinking about what does it mean in different contexts, what does COVID mean, and thinking about the health of people, specifically women, older women with chronic illness who were incarcerated during the pandemic. So I did a larger project, but what I'm going to focus on now is interviews we did with formerly incarcerated women who were incarcerated during the pandemic. That includes cis and trans women, as well as healthcare providers working inside. Excuse me, I have toddlers, so I'm always getting over a cold. I think most folks know the burden of COVID has been just incredibly high in prisons, much, much worse than other places. That was true in California. There's many strategies for thinking about COVID risk mitigation, especially pre-vaccine. But the one I wanted to sort of focus on and think about the implications of right now in my last few minutes were lockdowns. So for people who are incarcerated, what became a common strategy is that healthy individuals were placed in lockdowns, which means being, they can only stay in their cell, in their room, when there's an outbreak in their unit or in their facility. And so participants reported they would often be locked down in their cells for 23 or more hours per day. This could last for days, weeks, or even months at a time. We have people talk about being locked down for 38 days, during which time they'd only be let out of their cell for 15 or 30 minutes a day. And in that time had to choose if they wanted to take a shower, if they wanted to call their families, anything they needed to do outside their room had to be crammed into that really short window. And overall, these lockdowns were really associated with a lack of control over physical and mental health and worsening symptoms for both, right? So as we mentioned, caregiving and community is so important inside. So not only was communication and visits from loved ones outside were stopped, but if you had people you were close with who were outside of your cell, or even worse, outside of your unit, you might not have seen them for weeks or months at a time. So people talked about being isolated from all their sources of support during this really trying time. Additionally, people talked about the toll it took on their bodies. So this is a person who's describing she was used to working out. She walked sort of every day. That was good for her physical and mental health. Suddenly she couldn't do that anymore. So she's just described sitting on the bed all day. Stress got worse. She was crying, upset. Her blood pressure was spiking. She was worried she could have a stroke because of how high her blood pressure was. And it affected her health. And she said she felt helpless, right? So really, really detrimental effects on people. And this was sort of across the board. And so speaking about what healthcare access looked during this time, mental health specifically was really challenging. So mental health inside California Department of Corrections is delivered on a tier system. There's the highest intervention sort of intensive inpatient unit for people who are very, very ill. And it sort of, goes down from there. The general population, people who might have anxiety, depression, well-controlled bipolar, most of their therapy, most of their support or interventions for their care prior to the pandemic was in group therapy. Those stopped during the pandemic, which you can understand the reasons why, and didn't really resume and weren't really replaced in the way they think they were attempts to do in the community. So these staffing shortages, social distancing requirements meant that people, there wasn't really a way to provide care. Access to care was completely shut off. One person described they'd sort of go door to door asking you questions. Do you want to harm yourself? The only way to talk to someone was to yell through the door what was going on. And people didn't want to do that, right? They didn't want to blast their information for everyone to see. So many people were suffering. And what was tricky is that, we heard from providers, demand's never been higher. We heard from patients, all of this was going on. But CDCR actually said that the demand was lower, right? Because referrals come from the correctional officers working on the units identifying problems, and people weren't able to, weren't comfortable sharing out what was going on with them. And that was interpreted as not having as much of a need. So our data sort of really speaks back to this idea that even though demand in terms of referral was lower, that there wasn't a need for these types of services during this time that was actually increasing. And what I think is important to note is that, these lockdowns, which, you can understand COVID risk mitigation was strenuous and difficult to make choices, but it didn't actually stop the spread. There were huge outbreaks that happened across the entire prison system after these policies and procedures were in effect. So was this worth it? Is this what we needed to be doing, right? And this leads to sort of the questions that I think about with this. Lockdowns are a security tool, not a public health measure. They were used pre-COVID for many things, including health issues. But is that a tool that we should be using for thinking about health, given the structural and staffing limitations? Are there ways to engage in a pandemic response that could prioritize physical and mental health? What are we learning from this from the next time that we could potentially do differently? Are there ways to center health within a punitive context? And I'm really thinking that if we want to think about a health equity approach to care, we need to center community well-being, right? We need to remember the community people form, center caregiving that people do, think about the difficulty accessing care, of building trust with providers, which is even harder during this time, and center those themes when we think about advancing health inside prisons. So my current and future research in this area, I have two big buckets of things I'm working on. One is trying to advance new models for doing community engaged research with people who are incarcerated, specifically with older adults who are incarcerated. The other side is looking at the forced sterilizations that occurred inside of California's women's prisons and using that as a lens to understand health decision making, particularly in the context of trauma. So thank you so much. Quick acknowledgement to my collaborators and funders of that work, and I'm excited to engage more. Thank you so much.
Thank you, Dr. James. Wow, 3 amazing talks. I'm going to invite all of our speakers to turn on their video so we can see them. Inviting Dr. Pérez-Stable back to kick us off with some comments and or questions that he might have for our presenters. And also encourage everyone on the webinar that has a question for any of our 3 presenters to please put them in the Q&A. We'd love to hear from you, and they would love to field your questions. So I'm going to just turn it over to you, Dr. Pérez-Stable.
I never heard you call me that, Leah.
Okay, Eliseo, it's all yours.
Maybe when you were a student. So thank you for those presentations. Is really, really important areas. I'm just going to comment globally about the topics because I think they're all quite relevant. The end to HIV epidemic is one of the really important progressive programs that were launched under the Trump administration, not to be ignored. It is absolutely embarrassing that we have spent so much money and have developed such fantastic tools, and yet we see 70% of new infections happening in men who have sex with men who are men of color. And so this marginalized, this effort is just, and we know what to do. This is implementation science at its maximum. There are good models. I haven't reviewed this personally, but I'm told by my colleagues who are experts in this that the FQHCs, the Federal Qualified Health Centers who focus on HIV treatment actually do achieve 80–85% viral load suppression in their patients. And these are, remember, mostly people who are Medicaid or uninsured. And so it is doable. And so this whole issue of, there's 2 components here. There's this suppress the infected so that you get fewer new infections, and then implementation of PrEP. Primary care clinicians need to embrace PrEP and advance it with full energy. It's easier than prescribing a statin and less risky. And yet, when it first was rolled out, it was said, "Oh, I have to go to a specialty clinic. Oh, I don't feel comfortable doing this." It's embarrassing that we were there 10 years ago, and unless we get it done, it's going to continue. So I applaud you, Miranda, for working in this area. I think, like I would say to all the 3 scholars, build collaborations, bring your expertise in their different disciplines that I heard to work with clinicians, with other scientists on attacking this problem. We at NIMHC, I can tell you for sure, we don't get enough applications in HIV. And we have actually specifically set aside money for these 2 areas, so suppressing patients in primary care and community engaged research. Now, you're a little early in your career perhaps to think in those terms, but others aren't. And so and UCSF has a robust HIV research community, so I would encourage that. Rachel's work, I think, is also very timely in that you have this interest in climate change and health that has gained a lot of traction internally at NIH. So the Congress had, at least there was language in the congressional budget for fiscal 22 that was to designate $100 million for this topic. It disappeared or it was never there, depending on who you talk to. Much like our big increase or huge increase was reduced to a $50 million increase in our discretionary budget. But led by Rick Wojcik, who's the director of the National Institute on Environmental Health, there's a group of institutes that have formed a coalition around this. There are programs. In fact, I think there was some announcement released today, so I'm not telling you anything I shouldn't on this topic. There are going to be, different mechanisms, I think supplements available for this kind of research. So do look at it, do take advantage. It said what you presented was really complicated. And I think, figuring out how to focus it so that it makes it easier for the consumer of your colleagues in science. I get it, wildfires, everybody will know, not great housing. How do you get that data? And then you have a health outcome, preterm birth, on the pathway to adverse birth outcomes. Not always bad, but it certainly is a risk for that. So it sounds like you're onto the data sets, and you're going to be able to generate some relevant results. I'm familiar with the birth records. I didn't really know you could get housing data like you did, so that's applaud you for doing that. And so these linkages are challenging, and then the importance of particulate matter is huge. It's not the only thing. Any combustible is bad. And the implications go well beyond wildfires. It has to do with why people still burn, do combustion outdoors in urban areas where there is no circulation of air. So to take that for what it may be. And Jennifer's work on incarceration, you said incarceration and end of life, and then went quickly to this COVID effect. So you touched on all these big issues. I think we've never done enough research on end of life care. I think we fail our patients in end of life every day, all the time. I don't have an answer to it, but I'm just saying that it really is an area that needs more clinical and scientific input. I do think that it has been underemphasized in communities of color. In a big way, and by researchers of color. So I do think I think that would be a good thing to get back to. But getting to the issue of incarceration as a social determinant, so the history of incarceration, how often did we ever ask that in practice? I don't think very often I ever asked people, were they ever incarcerated? And you almost felt like embarrassed to do it. Are they going to think negatively of me? Should we do it? I mean, it's sort of like those questions when you start asking about something that's sensitive, yet it's important for health. You have to learn how to navigate that because there's clearly a risk factor. There's a risk factor for short-term bad outcomes that's been shown. It's a risk factor for being socially disadvantaged, and people won't give you jobs. It disproportionately affects men, but not exclusively, and it disproportionately affects men and women of color. The data on incarceration are quite clear, and then there was a policy to use incarceration as a tool for controlling crime much more prominently in the 1990s. All those individuals who were incarcerated and are out, are now in middle age or older age. So what's gone on with their health? And there are some areas of interest. I remember, I don't know if she's still around. Bree Williams was interested in older adults in prison. I'm sorry, who had been there for literally decades and were now aging in place in prison, and sort of the injustices and the issues. And then finally, you talked about lockdowns. Someday we'll retrospectively think about what was or wasn't done with the lockdowns in incarcerated individuals. It was horrible. Right now they're basically limited. It's like now you're solitary confinement for everybody. It's really horrible, and we know how inhumane that is. But in society, I think we probably overdid the lockdown thing. We kept kids out of school for, in some cases, almost 2 years. The damage that has done, I think, is yet to be fully understood. I know it's been tough going back, and kids are out of school now because they get infected. Teachers are out, and I hear that all the time. But again, it has mostly been children who are poor or come from more working class backgrounds or minority backgrounds who have been disproportionately affected by this. and similarly, the learning, and the young people. So the young, the impacts on mental health, I think we're just really beginning to get a handle on what this is going on. So thank you for that. I think you see, I focus on the theme because their themes are really important. You're very focused on a narrow area at this stage, as you should be. But think big. You got to grab people about your research. So I'm thinking, when you say wildfires, incarceration, housing, HIV, and the HIV epidemic, then you grab interest and then you go from there and build your collaborative networks. Thank you. And congratulations, by the way, to all three of you.
Thank you so much for that commentary. That was great. And thank you for all our presenters. So I have a question for each of you, and I'll just present them all and let you take turns answering them. But especially for Dr. Hill and Dr. James, if both of your work featured community engaged research pretty prominently, and these are often populations that are called hard to reach populations. So I was wondering if you guys could speak a little bit to the process of engaging those populations in your research. And then Dr. Sklar, I really commend you for including some policy goals in your aims and in your work, and just was wondering if you could touch on how to get from research to policy change. So I don't know who wants to take a first stab.
I can go. It hasn't been hard for me to reach populations that are medically underserved. I worked in community health outreach in the South a lot. And so I know about being pleasantly persistent and how to identify key informants. And so it's not too hard for me. It's just really like a phone call away, and you have to be able to sell yourself as a researcher and connect with their mission. And I think that is really the key for me, is with these community-based organizations and these other types of hubs that people gravitate to, where they get economic resources, where they get a number of other supports. It's never been hard for me to either call, email, or show up to those places and say, look, I'm interested in this. This goes along with your mission. How can we work together? And sometimes it's just kind of a no or a non-response. And then sometimes it's a yes. And when it's a yes, that's when it works. And so that's really my method that I use.
Yeah, I can jump in too. A couple things. So, I've spent the last several years developing relationships with community organizations and folks who do work in this area. And I think, it's something that I know Kim Rhodes and the Cancer Center and many others speak to about, but the importance of year-round, bi-directional, non-transactional relationships. And I think that that's the key. So I think if I had just tried to recruit this population of people, I would have not had any luck sort of just putting up flyers or whatever. I wouldn't have reached anybody. But when your research is done in partnership with people who both can vouch for you and say, hey, will you do this? And it's coming from someone they know, that's one piece, which I want to emphasize. Coming from someone in the community is very different than coming from someone who looks like the community, which I think we often conflate as being the same, and they're not. And then also, moving forward, and now sort of after I sort of started this initial pilot, my research has been driven by community needs. So it's people I work with saying, I think we need more research on this topic. Can we work together to do that? Which I also think is very different than me coming in with my own research agenda and trying to find people to do it. But one thing I want to note is I've had interviews I've done with people where people have said, what are researchers going to do? You don't know anything. You can't solve anything. Nothing ever happens from research. And I think holding space for that and centering the fact that research has often failed people a lot, and they don't hear anything about it. They don't see any benefit of it, and being really open about the fact of like, what can we actually do together? And thinking about how you're compensating people for their time, what they're getting back, how you're sort of immediately returning your findings to community. Because I think, I published in a really fancy journal means nothing to, anybody who's not you. So.
I guess I can go now. It's an interesting question that you ask, Dr. Garcia. For me, I think keeping policy goals in mind is really important, but being careful not to make my science have too much of an agenda, so to speak, so as to be discredited. This is something I'm constantly sort of struggling with. For me, focusing on the data and then working, I'm lucky to be at an institute at PRE where we have an outreach team, where we have a policy team to get our findings into the hands of activists and policymakers who can do that translation. But yeah, for me, I think as a scientist, I'm constantly having to walk that fine line between, having an agenda and maybe discrediting my science because it's too much of an agenda, and doing meaningful research that makes change. So I think keeping the policy goals in mind, but focusing on the data is my approach.
Great. I have lots more questions, but I think we're running out of time. And so I want to be respectful of the fact that it's late in the day, particularly for Eliseo, who's on the East Coast. And but I just want to, first of all, congratulate the three of you on your great talks, on your great work, even more importantly, and on your awards, and a little more by email to follow on that. And thank Eliseo, Dr. Pérez-Stable, I'll say it again, even though he claims he hasn't heard it from me. I've perhaps been disrespectful my entire career. But thank you so much for joining us, for helping to found MERC, for all that you've done at during your time at UCSF, which is not forgotten, and for the leadership you're showing nationally at NIMHD, and for really sharing your time and your wisdom with us here today. We're very, very grateful. And I want to thank too, in addition to thanking Maria Garcia and Jane G, who of course have been integral to all of this, I want to thank two other people who've been behind the scenes making this happen. Giselle Aguayo Ramirez and Anita Ponce, giving us analytic and administrative support. We could not have done it without you. And of course, everyone who's been on the webinar and stuck it out on a Friday afternoon, we really appreciate it. So please, if you're interested in learning more about MERC, you see our how you can reach us, and also go to our website. And we'd love to hear from you. Great. Thank you very much to everyone, and enjoy your weekend. Bye-bye.
Thank you, Leah. Bye.